السلام عليكم ورحمة الله وبركاته. Hello, January 2026 group. Welcome to our very first session. We are going to start with gynecology module, and as you can see, I'm your host for today. This is Dr. Nada, and we are going to start with amenorrhea and hirsutism. If you don't know, my subspecialty up to this moment is gynecology, and I'm trying my best to have fetal medicine also, but I'm not done with the fetal medicine degree. So up till now, I'm not going to call myself fetal medicine specialist. So mainly, most of my career, I have been dealing with gynecology cases, and I love gynecology. In gynecology clinic, guys, you are going to meet three types of women, mainly. The first one is a woman with menstrual irregularity. And the subtypes is going to be heavy menstrual bleeding or amenorrhea. The third is infections. And many people think those are mainly, okay? Of course, we are having other cases, but those are the main one. Those women, they think that their management are easy, okay? And they always look at gynecology as, okay, this is the easy subspecialty in obstetrics and gynecology. But let me tell you that they are taking it easy, okay, and for granted, and they are having very bad management for those cases. And this is why the patient is going to have once, twice, three times consultations for the same problem. My aim today, not only to make you good in gynecology, but also the best in gynecology exam questions. Those are every exam question. Definitely, you are going to have a question about amenorrhea. Not only one, of course, but definitely at least one about amenorrhea, one about heavy menstrual bleeding, one about irregular bleeding and differential diagnosis, whether she is endometrial hyperplasia or not, I don't know. You are going to figure out from the scenario and choose the best management. And of course, you are going to have something like DSDs or pediatric gynecology. Okay, so amenorrhea, let's start with amenorrhea. And this is a good example of what are the eRCOG resources. From where I would study. If I don't want to study from your summaries and I want to read a guideline regarding this topic, from where I should read. Actually, amenorrhea does not have a guideline. So we are depending mainly on the strategy module, which is a basic knowledge. Okay, this is one of the basic knowledge topics. And of course, I depend on many other resources, some from the European guidelines, and of course, TOG articles. We have two TOG articles that talked about amenorrhea, but not as the main issue. The first one is the WHO type 1 anovulation. The other one is DSD. And I think we are having the PCO as a TOG article, but now we don't depend really on it. We depend mainly on the ISHRI guideline for PCO. So as you can see, there are a lot of resources. If you wish to go through them, just ask me. I'm going to write them down to you. I don't really remember if I have put down the resources here. No, I didn't. But if you wish, guys, I can tell you what were my resources, of course. I don't mind at all. Okay, I'm not telling you go only through my summaries and only read them. They are enough. I can guarantee you that they are more than enough. But maybe you are like me. I'm someone who like to read guidelines. So if you like to read them, definitely you can. And as I told you, amenorrhea, for example, you need to read WHO type 1 anovulation TOG article. We have the summary for it. And if you don't still have the link for the TOG summaries, let me give it to you. Okay, I know we are in the beginning of our course, so things are not really clear for many of you. Some of you have it, some of you may have not heard about it. So I'm going to bring it to you right now. Okay, and send it to the group and send it here also. We have a Google Drive for TOG articles because they are abundant and they are very heavy. And the most important TOG articles, you are going to find it in your course. But others, they are in the Google Drive. So here, for example, okay, here, if I open the gynecology study material, okay, they are distributed into topics, as you can see. Okay, so if I open the menstrual disorders here, you are going to find the differences of sexual development disorder. This is a TOG article. Okay, surgical management of HMB, TOG article. Heavy menstrual bleeding in adolescence, TOG article. All of them are TOG articles because there is no guideline for them, just like amenorrhea. But if I bring you the resources of amenorrhea, they are going to be many, okay? And we have the UEE and fibroid management. This is also by Dr. Rabah, depending on many resources. Okay, if we go through menopause and HRT, for example, you are going to have this one. This is a TOG article. This is PMS guideline, the British Menopausal Society. This is a TOG article. This is a summary. This is nice, okay, and a TOG article. This is nice guideline, okay? So the most important TOG articles are already there in your course category here, okay? For whatever module, you are going to find nice guideline, or for example, this one, all of them are TOGs. The less important, okay, they are here. Or let's say they are subspecialty more. Okay, sorry, this one, TOG summaries. This is the link. Okay, and I give you the permission. So please try to use the same email that you have in the website. Okay, I'm going to send it to the group also. Here we are. Okay, so as you can see, they are subdivided into the volumes. There are so many. You can find the PGCS summaries also, the SIPs, scientific impact papers. You can find the FEGU summaries and old TOG articles, but they are essential for the exam. All TOG articles are mainly 206, 17, 18, 19. After this, you are going to find that they are in volumes, just in case you want to go through them. The summaries are more than enough, trust me. But in case you want to read the guideline itself, of course you can. How I would stop you? Of course you can. For example, I'm someone who prefers to read the guideline itself, not the summary. It's me, I'm OCD, okay? I'm someone who is having problems. Honestly, wallahi, if I want to go through like 60 pages instead of having like 4 to 6 pages or 10 pages, I'm having a problem, okay? But it's my right. I want to go through the guideline. Okay, you have time. You have time. And when you go through the sessions and have a read for our summaries, you are going to get used to my way in summarizing a guideline. Because there are ways, honestly. So someone is going to accept it. Someone is going to feel like, no, I cannot really accept it. I want to see the guideline myself. Okay, you can see the guideline yourself, definitely. Who can stop you? Okay, so here we are. You have everything in your hands. As I told you, not every TOG article is important. So this is why you need to be aware of what's there in the course. And then if you wanna go through more, okay, you can go through more. Subspecialties like oncology, like fetal medicine, like ART, TOG articles are extra TOG articles. And don't worry about it because we are going to cover them during revision. Don't ever worry about it. We always cover everything by the end of the course. Okay? Now I can start my session. So here we are. We are going to talk about amenorrhea. And this is someone who is coming to you saying, I don't have period. So the next question would be, have you ever had period or not? So if she didn't have period ever, this is primary amenorrhea. If she got a period before and now she's not having period, this is secondary amenorrhea. So the important question would be, definition of delayed puberty or primary amenorrhea. Can you remember, guys, from the very beginning, who is the young lady that we can tell that she is having a delayed puberty? We have two numbers, 14 and 16. So if the young lady is 14, she's 14, and she's not having secondary sexual characters, this young lady is having a problem. This young lady is having delayed puberty. Because I should be having at least breast bud, at least some hair in the groin. Okay? The axillary hair is not a must, by the way. The breast bud is the first puberty sign. So this young lady is 14 and yet there is nothing. No breast bud, no groin hair, or the groin hair are still very scanty. They are not coarse, they are light, thin, okay, tall hair, not thick and curly. Okay, so this lady here definitely she's having delayed puberty. Another young lady, she is 16 and she is having secondary sexual characters, but no menses. This is also a definition for delayed puberty. Okay, so let me ask you, if you are having a young lady, she is 14, she is having secondary sexual characters, but no period yet. Are you going to tell her this is delayed menses or delayed puberty and let's have further investigations? I'm going to repeat again. She is 14. She is having secondary sexual characters, but no menses. Normal or abnormal? I'm going to accept it and wait until she's 16. I'm going to accept it. Yes, exactly. Okay. So why? Because this could be familial. But my main aim is that she had developed normal secondary sexual characters. And what I mean by secondary sexual characters, she is having now more than breast bud, okay? And also she's having coarse, curly, inguinal hair or groin hair at least. Okay, so at least I'm having this. I'm having breast bud. I don't care about the size of the breast, by the way. This is also hormonal, genetic, and familial. I just care about the presence of a breast bud. Don't have a, okay, no, this is a complete breast development. But there is no hair. This is abnormal. This is something abnormal. Okay, so I at least I need a breast bud and a groin hair. Okay, so I can wait to 16 and then I'm going to say if still no menses, this is abnormal. Okay, so now we know the definition for delayed puberty. Okay, tell me now, if I'm having a lady with amenorrhea, what should be my steps? How should I think? You should think of the track. The track starts from the hypothalamus. So I'm having the hypothalamus and the pituitary and the organ or the primary organ, which is the ovary. The ovary could be not working, pituitary could be not working, the hypothalamus could be not working. Something in this axis is not correct. Okay? How I would know? Where is the problem? First of all, guys, signs and symptoms. We depend on them mainly to have an idea what would be the best next step. Signs and symptoms, definitely. Number one, do I'm having a secondary sexual characters or not? Am I having normal height or not? A normal height is something reassuring, but very tall ladies or very short ladies are having something wrong. So, okay, signs and symptoms. Number two, I'm going from the history to ask her if she is taking any medications, right? If she is having eating disorder, if she is having a great weight loss recently, or she is doing severe excessive exercises. All of this from history is very important for the next step. Our very next investigation for a lady who had developed secondary sexual characters, even if she's having amenorrhea, is pregnancy test. Please don't forget it, even in primary amenorrhea. Primary, yes. She haven't seen her periods yet, but she's having secondary sexual characters and she's sexually active. I should rule out pregnancy. In case this is a scenario in the exam and they didn't say anything about her sexual activity or whatever, but they said examination is normal and she is having primary amenorrhea, please perform a urine pregnancy test. Medico-legally, this is for your own safety. Before giving her any medications, you should make sure she's not pregnant. Okay? From examination, also this is important for your exam question. They are going to tell you there are breasts, there are no breasts, there are groin hair, there is no groin hair, there is normal vagina. No, there is blind-ended vagina. And blind-ended vagina means that we are only having the lower third of the vagina. Lower third of the vagina has nothing to do with the upper third or upper two-thirds, because the embryological organ is different. Let me remind you from part 1 that the tubes, uterus, cervix, and the upper two-thirds are from the urogenital sinus. But the lower 1/3 of the vagina, from the Mullerian ducts or tubes. The lower 1/3 is from the urogenital sinus. And this is something that's going to develop in males and females, both of them, according to the presence of the Y chromosome and according to the presence of active testosterone. This could develop into a vagina, or it can be a remnant and a part of the urethra in males. Okay, so urogenital sinus here, this part is going to form the lower third of the vagina in females. In males, it's going to be a part of the urethra. When I'm having DSD, or disorders of sexual development, which means that I'm having inactive Y chromosome, or a resistance to testosterone, or a problem in the receptors, I'm having a disturbed anatomy now. So sometimes internal organs and external organs are going to be something between male or female, according, of course, to how deficient the enzyme is, how unresponsive the receptor is. Okay? There are degrees. And this is why we have complete pictures of some syndromes and incomplete pictures of some syndromes. But you are going to find that this patient, abnormal patients, are having blind-ended vagina. Why it's blind-ended? Because this is a part of the urogenital sinus, and there is nothing further. Nothing further. Got it? There is no upper part. There is no uterus, no tubes. My question now is, if this female is XX, even if she's having only the lower part of the vagina and nothing above, what about the ovaries? Are we expecting to see the ovaries or not? If she is XX, do you expect to see the ovaries or not? Any idea? Okay. Actually, it again depends on the embryology. Yes, we are going to see ovaries. Yes, ovaries had nothing to do with the Mullerian system. The ovaries, embryologically, is going to develop from a total different origin. Okay, we are talking about germ cells. Those germ cells. My pad is going crazy. I cannot using efficiently. Those germ cells, guys, has nothing to do with the Mullerian ducts. So yeah, it's there. Why it's there? Because this is a female, XX. If she was XY, I don't forget about how she appears. Forget about how she appears now. Genetically speaking, XY, the presence of Y chromosome is going to force her body not to form an ovary, and they are going to form a testicle, right? It's going to form a testicle. The development of the testicle and the development of the ovary depends on hormones. But the origin, the very beginning, depend on the chromosomes. If I'm having XX, I'm going to develop ovary. If I'm having a Y chromosome, I'm going to develop a testicle. I'm just trying to give backgrounds and develop general concepts, okay? Because I don't like to go through differential diagnosis as if I'm reading a book to you. Okay? If you don't like this and you just want to go through differential diagnosis, I can go through, and it's going to be easier for me, by the way. So I'm just trying to make you think systematically. Number one, signs and symptoms. Number two, examination. And examination is very, very important, because sometimes it's easier than just having a DSD or whatever. It could be structured. And by far, this is not exam question. Structural abnormalities are something with the septum, like imperforate hymen or a transverse septum. This could be her problem. But mainly they love DSDs, or disorder of sexual development. Okay? This is what they really like. And they are going to be very easy for you in the exam. So don't really care about it now. Okay, so we have examination. The examination revealed a normal secondary sexual characters. I'm going to order hormones. I want to see her axis. What's going on with the pituitary? What's going on with the primary organ, the ovary? Okay, so I can order the FSH and LH and prolactin, whatever you like. Everything, estrogen, if you want to go for estrogen, if you want to go for prolactin, okay? Plus or minus thyroid, if she is having thyroid symptoms and signs, because thyroid, of course, one of the most important endocrinology organ in this pathway. Hypothyroidism is the most common reason why women are having hyperprolactinemia. So I'm going to think about it. Okay, so in the exam, if the scenario is telling me this woman is having lethargy, weight gain, hair loss, okay, I'm going to order thyroid. Fine. But if from the examination you find abnormality, like blind-ended vagina, okay? If you find from the examination that you are having a blind-ended vagina, do you think that hormonal profile is your best next step? Look, guys, in practice, you can perform different type of investigation at the same time. In the exam, they really focus on what would be the appropriate next step. So if I'm having a woman here and she is having abnormal vagina, what kind of abnormality? They are telling you this is blind-ended short vagina. What do you think? What would be the best next step? Tell me out loud. Okay, Dr. Wajah is saying scanning. Good point. Okay. So she's going to order ultrasound, I think. Okay, to make sure if the uterus is there or not. Okay, if I told you from the scenario that this lady is having normal secondary sexual characters, but she's having scanty pubic hair, would you really care about scanning now, or there's something more important you wanted to exclude? I want you guys to not memorize every investigation for a specific disorder. I want you to think logically. Okay, why karyotyping? Why? What I said that make you think of karyotyping? Don't tell me diagnosis, please. Don't tell me a diagnosis, because this is not correct in practice. In exam, okay, maybe, but not good in practice. What I have said in the scenario that led you to choosing karyotyping. No pubic hair. Okay, so the absence of pubic hair is something abnormal with a normal XX female, right? Again, having abnormal pubic hair is something abnormal for a normal XX female. XX female should be having ovary. This female should be having hormones, and those hormones should give her normal secondary sexual characters. So if I'm not having a complete picture of secondary sexual characters, I'm going to doubt that she is XX. Okay? I don't care what she is now, okay? Because XYDSDs are many. This could be AIS, this could be SWARE, this could be LH receptor deficiency, this could be many things. Of course, in the exam, I'm going to teach you the typical scenarios, but I need you to think in general, a big thinking. Having abnormal secondary sexual characters, that means that this could not be XX. Even if she's having breast, yes. She could be having breast, but she's not having pubic hair. How come? Simply estrogen or testosterone, so both of them, by the way, the testosterone could be converted into estrogen preferably. Again, if you remember back in part 1, there is an enzyme here. Okay, I don't want to remind you of part 1 again, but we are having an enzyme here that works in both ways. So we can have testosterone transforming into estrogen, right? So yeah, even if she's having, he is XY, okay? He is XY. And he's having testosterone. For some reason, this testosterone is not working. Okay, for some reason. This testosterone now, which cannot work on the cells because of a deficiency in the receptors, or the amount of testosterone is not really good. So I'm having peripheral conversion of testosterone to estrogen. This is going to render you with a normal appearing breasts. And the more testosterone converted by aromatase into estrogen, the more the breast is going to be bigger. Okay? Some cases are going to have female phenotype, which means they are looking like a female until the age of puberty. until the age of puberty. And after the age of puberty, they are going to appear something between males and females. Number one, they don't have menses. Okay. Number two, they are getting taller than other females. Their breasts are not getting bigger. They are having the body shape of a male. They are becoming somehow muscular. What is this? This is mainly Swyer syndrome, guys. This is mainly Swyer syndrome. Swyer syndrome is something that is related to the receptors, okay, and the testosterone released from the testicles in a male, but they are not really active testosterones until the age of puberty. And this is why they start looking like a female, but by puberty, they are changing. Adult onset CAH, she is a female all the way. CAH is something related to enzyme deficiencies in the steroidogenesis. So it's not genetical. She is always XX. And usually her problem is going to be hirsutism and secondary amenorrhea. Okay, this is not DSD. And this is why I want you to think widely. I don't want you to remember conditions by its name, or you will be lost. You will be lost through investigation. So mainly this here, you can use it for revision. If you need more details, okay, I can send you another file if you wish. But for the exam, really, I don't want you to think deeply. Never. I don't want you to think deeply. I want you to think by the presence or absence of secondary sexual characters, just like this algorithm. If it's there, just like Dr. Wajiha said, if it's there, I'm going to order mainly ultrasound. Why? Because I need to know why this female is not having menses and why she is not having a normal vagina. Even if they didn't say anything about the vagina, they just said in general, the patient is having normal secondary sexual characters. Okay, and she is 16, as I told you. So she must be having menses by now. Okay, this is primary amenorrhea. They didn't say anything about examination. Your best next step would be ultrasound, not karyotyping. You know why? Because she's having normal secondary sexual characters. So by far, she is XX. By far. Yeah, it may be constitutional, but constitutional is not accepted over 16. You should exclude pathological causes. And if everything is normal, I would say constitutional or familial. This is why we are saying wait until 16 and then investigate. Got it? Okay, so I'm going to start with the ultrasound. If the uterus is present, okay, so something is not correct with the outflow tract. We can have another look, or if it's not already done, I can have a look on the vagina. If the uterus is absent, we are dealing with the eMRCOG syndrome or Mullerian absence. Okay. This Mullerian absence means I'm not going to find uterus tubes or upper part of the vagina, but the ovaries are there. Why I'm saying this, I'm stressing over this, because this lady here can be optioned any fertility options, and quickly. We should do this quickly because we are not really sure of her ovarian activity. So she should make her mind about fertility wishes. I can take out eggs. I can give her ovarian induction, and I can take out eggs and freeze them for future use. Of course, not with her, because her uterus is absent or infantile, or it could be one of the uterine anomalies in case of incomplete absence. Okay, sometimes it's going to be septate or didaphilus or unicornuate. Okay, so according to the case, if we are having a complete absence of the Mullerian duct, so absent uterus, so she can have a surrogate mother, but with her ovaries, with her own eggs, right? So this is important. If it came out to be absent, so the uterus is not there, and they told you that this young lady is XY by karyotyping, who is the female that is having approximately normal secondary sexual characters, but she is XY and have no uterus? This is the famous but not common complete AIS. Complete AIS, guys, is a female. She is only male genetically. Otherwise, she is female by features, hormones, everything. So now I'm going to talk about every and each condition. Okay, now we know the general idea. So let me talk to you about AIS. What is AIS? Do we have something here related to hormones? Okay, this is not for us now. We are talking about other lady. Okay, the AIS lady. This is a complete androgen insensitivity syndrome. The lady is looking as a lady. The body is a female. She is raised as a female her whole life. But she's going to have sparse hair on the genitalia, sparse hair in the axillary area, okay? And no menses, of course. Sometimes a doctor is going to think that the scarce hair or the very little amount of hair in the groins is familial, okay? Because she is a female, she sounds like a female, she looks like a female. So he's going to skip this sign. He is going to figure out that this is really AIS after doing the ultrasound, and he's not going to get uterus or any part of the Mullerian ducts, and even no ovaries. Karyotyping is going to reveal that this is XY person. But let me tell you that those are complete females. Why? Because they are insensitive to the testosterone. So they are forming testosterone. They have testicles, by the way. Internal testicles, mainly abdominal or pelvic. They haven't distended because the distend of testicles are the responsibility of active testosterone. or to be specific, testosterone only. The active testosterone is responsible for the appearance of external genitalia. The DHT is responsible for the external genitalia. Testosterone alone is responsible for the descent of testicles through the inguinal canal outside the body. Her body is insensitive to testosterone. It's not working. Number one, this lady here, the first thing to offer to her is the removal of those abdominopelvic testicles. Whether you discover they are here or here, remove them. Why? Because they are prone to malignancy. And already, she is not going to take any medications. And of course, her chances to be pregnant is 0. But we can offer her lifestyle and everything. And this lady here is a total lady. Okay? She's a total one. We are not going to offer her HRT. She does not have a uterus. She does not have ovaries. She is having the estrogen from the peripheral conversion of androgenic, at least adrenal testosterone. Okay, so even if we remove the testicles, she still have the adrenal testosterone. So she's just fine. What she really needs is psychological support and removal of the abdominal gonads. And this is why sometimes they are going to tell you in the scenario that during childhood, she had bilateral inguinal hernia, or she had operation of bilateral inguinal hernia. Can you guess what is the components of this hernia? Can you guess? Yeah, the testicles. The testicles, okay? Those are the components of the hernia. So this is one of the golden words in the scenarios. So this is simply AIS. Very clear, very common in the exam, especially the complete one. Because the partial one here is very vague. The male type is very vague. They can be looking like a female, they can be looking like a male. Again, the partial insensitivity can give you any picture. But the complete AIS is the usual question in your exam. Okay? Okay, so I'm still here. If I get back, I'm still here. I have done the karyotyping and it revealed that I'm talking about XY person. Other differential diagnosis of someone who is having normal secondary sexual characters, but turned out to not having a uterus and XY chromosomes. As I told you, this could be Swyer. This is Swyer. No. This is Swyer. So Swyer syndrome here, guys, is a problem with, as you can see, we are having a problem with one of the parts of the testosterone or form of testosterone. This patient is XY. Okay, so he's going to have testicles. Okay, but they are having a problem with the SRY gene. Their problem is they are going to have a strict testicles, but according to which type of testosterone is there and whether the AMH was formed or not. So this is why they are having a picture of both males and females. They are not Aphrodite. Aphrodite means you are having both of them in the same person. No, in case of Swire, they are starting to look like a female, and until puberty, when they get testosterone abundantly secreted from the straight gonads, they are going to have some features of male, or at least they are going to have amenorrhea. Okay? They are not easy to diagnose, by the way. Not easy, not at all. Those patients could be having no active testosterone, the DHT, and this is why their external genitalia are looking like a female. Complete absence of DHT. And because the gonads, again, they are not completely functional, if you can say. They are not completely functional. So Sertoli cells are not really active. They are not secreting AMH. So some of the Mullerian duct system is going to be formed. So she can be having infantile uterus. She can be having vagina, but abnormal. She can be having tubes. Not all cases. Some cases. Some cases. And if the testosterone is totally not there, she's not going to have any Wolffian duct. So, no prostate, no urethra like males. She's going to have urethra like females. And of course, no scrotum. And the testicles are all also going to be abdominal or pelvic. So, in general, tell us how they are going to look like. They can be having some of the Mullerian duct system components, but definitely no others. They could be having a range of sexual characters, from having a small breast up to nothing. Again, according to how functional the testicles are. It all depends on the SRY gene. Is totally absent, okay, or it is not functioning totally. So, in the exam, Swyer syndrome, a tall female that was raised as a female, but by puberty, she's becoming taller than others. She is having wide pelvis, but she's not having menses. She is having structure of a male. Now, she is like becoming male structure more than a female. The rounded body, the fatty body, it's not there. Okay? You know, guys, you can say she's going to be looking like a trans woman. Mainly. Yeah, a trans woman. By puberty. So again, if I do the karyotyping, I'm going to find that this is XY. How I would differentiate between this person and AIS, they are going to tell you that there is a small uterus. They are going to tell you that her breasts are not well developed. a mixture of things, and she stole. And this is why swear is not very famous in the exam. I'm just telling you, just in case. Do we have other problems? Many, many. We can have a deficiency in many enzymes in the steroidogenesis. So he is a male. Genetically, he is male. Internal parts are totally normal, but the external parts are looking like a female. This is something related to deficiency of the enzyme responsible for transformation of testosterone to dihydrotestosterone. The dihydrotestosterone is the active form of testosterone, the one responsible for external features. So if I'm having normal internal features, but abnormal external features, this is mainly absence of DHT. Why you don't have DHT? Deficiency, total deficiency of the enzyme, the alpha reductase enzyme. Okay, this can be exam question, definitely. Why not? Okay, so she was born as a female, raised as a female, and by puberty, she's not having menses. She's having blind-ended vagina. Okay? This is like total absence of 5-alpha reductase, because enzyme deficiency depends on the level of deficiency, by the way. If it's there but not totally absent, she is going to be having feminized genitalia, not a total female genitalia. So yeah, there is a phallus, but very small. Yeah, there is a scrotum, but undescended testicles, sometimes hypospadias. Okay, so a range of external features, but total absence of 5-alpha reductase. When should you diagnose it? When you find that there is normal male internal reproductive tract. Prostate is there. Benign urethra, yes, we can be having benign urethra. We can be having prostate urethra. Okay? But the external features were vague, so she was raised as a female and now she's having amenorrhea. Okay? We also have Klinefelter. This is not usually a common case, but guess what? It came as a recall that a female is coming to you. She stole. She's having normal breasts. Okay? And don't remember the scenario exactly, but she's having amenorrhea also. And I think I just wanted to remember how I told them I don't mind how she represents herself to us. She represents herself to us as a female. Okay. She was raised as a female, or whatever the person is representing them to you. Put it aside. Look at the physical examination. So if the physical examination revealed that this person is not having estrogen, this person is having high FSH, this person is having testosterone, but not high testosterone. Okay, so he's having low testosterone, low estrogen, and high FSH, and she's tall, and she's having small breasts and female body hair distribution and large clitoris, yes. What would you think? Or what would be the best next step, at least in investigation? If I told you all this, what would be the best next investigation? They gave you in the scenario that the FSH is high, low testosterone, low estrogen, and the patient is tall, okay, and she's having small breasts and clitoromegaly. There is a differential diagnosis, by the way, for this. But what would be the best next step? Karyotyping, excellent. Yes, excellent. Karyotyping. So, wallahi, if it came out to be 46 XY, this is maybe square. If it came 47 XXY, this is Klinefelter. See, they can present the same. But most of Klinefelter, they are having small phallus, they are having small testicles or small scrotum. They are tall, raised as males, and usually they come as a case of male infertility. But everything is possible. Everything is possible. Other causes of amenorrhea metabolically is what's called galactosemia. No, there is no internal female organ. Excellent, Dr. Wajah, good point. In Klinefelter here is not going to have female organs. No, there is no female organs, not like Swyer. Swyer, there is a possibility that you could see infantile uterus. You could see tubes. Yes, excellent point. Here in the galactosemia, this is a metabolic disorder where galactose is very high, and galactose could lead to brain damage and eye manifestations and organ damage. So if it appears in the exam, the main symptom, not only amenorrhea, she's going to have multiple organ failure. Multiple. And if he is a male, he is going to have also subfertility. So we are talking about hepatic damage, renal affection, brain damage, cataract. Okay, why I'm saying so? Because again, for some reason, I'm not really sure it appeared in recalls or not, but they were talking about a case of amenorrhea with eye manifestations or cataract, and I think something CNS. So yeah, this could be galactosemia. Another case, which is very famous, and you all know her. No, not Turner. Yes, Kallmann syndrome. Kallmann syndrome, again, this is a hypothalamic cause. Why Kallmann syndrome is one of the causes of the shutdown of the hypothalamus and of course the pituitary. So it's genetic disorder. It's famous of normal genetic karyotyping. Normal, okay? The symptoms are delayed puberty, and for males and females, by the way, and it affects males more than females. And of course, symptoms. So the symptoms could be hearing loss, cleft palate, and guess what? Anosmia, the very famous anosmia. But hearing loss was not very well known to many candidates. And this is a recall. A patient with primary amenorrhea and hearing problems. And they told you that I think the FSH was low. And of course, the estrogen is low. Prolactin is low. So you were thinking, what is this? Because everyone knows that Kallmann syndrome equals anosmia. No, let me tell you guys, Kallmann syndrome she could be having hearing loss also. Okay, so take care of this. And fine, we have also the LH receptor defect, according again to the degree of defect in the receptors. We could be having cases of complete external female genitalia and up to a normal male genitalia. And this can happen to males and females, but it's more apparent in males, of course. In females, it could be like a subfertility problem more. But for males, it's going to be a problem because they were raised as a female, and by puberty, there is no menses again. Right? So this is why it's not also famous in the exam. But you can, let's say, differentiate between this and AIS or other problems in testosterone, that in case of LH receptor defects, now the testicles are not able to produce testosterone. Think about it. LH, where is my pen? Yeah, LH work on the Leydig cell, and the Leydig cell is the one responsible to secrete testosterone. So if I'm having LH receptor defect, that means that the Leydig cell is not going to secrete testosterone. So testosterone in LH receptor defects are low, while the AMH secreted by Sertoli cells, and Sertoli cells are stimulated by FSH, not LH, is working. So the AMH is going to be normal or high, while testosterone is low. In case of 5-alpha reductase, I'm only having a problem with the conversion of testosterone to active testosterone. Right? So of course, I'm going to have normal or high testosterone up to the level that it causes negative feedback on the pituitary, and this is why I'm not having high AMH. Anyway, alhamdulillah, this is not common exam question, but who knows? Who knows? They are there, and they are mentioned in the TOG article, and they can come to you. Turner is very famous case, so I'm not going to talk about Turner in depth. Turner is very obvious from the scenario. The lady with primary amenorrhea, and she's having the web neck. She's very short, shorter than any other female in her age. And she could be having cardiovascular abnormality, or they can give you the cubitus valgus. So very, very obvious. This lady here, she is having hypogonadotropic hypogonadism, just like ovarian failure. So the estrogen is low, androgens are low, and of course the FSH and LH are very high, just like a menopausal woman or ovarian failure. Okay, in case if we get back here and have a final look at this algorithm, the most tricky or the trickiest cases are the DSDs. Other cases that can have amenorrhea, who are having a problem with their hormones, okay, they are having ovaries, they are XX. So now I'm looking at the axis. So I'm going to order the FSH, LH, prolactin, whatever, and make my mind if this is something related to the hypothalamus or the pituitary. If the FSH and LH are low, that means that the problem is from the hypothalamus or the pituitary. If they are high, that means that the ovaries are not working, and this is why the pituitary is trying its best to secrete more and more gonadotropins, maybe in a trial that the ovaries are going to work, which is called gonadal failure. Okay, guys, so this is mainly everything important about amenorrhea. The treatments are really easy. You are going to give HRT for those who need it. Make sure you did gonadectomy in Y chromosome conditions. Fertility treatment, again, depends on the abnormality. So in cases of hypothalamic pituitary causes, because this was mentioned in the TOG article, if the patient is not yet puberty or she's not in the age of puberty, I can give her the GnRH pulses because I want to mimic normal puberty. But if she already now 16 or more, okay, I'm going to give her hormone replacement therapy because she needs estrogen for her bone formation, for her bone maturation. I'm not speaking about puberty anymore. I'm speaking now about her cardiovascular health, her bone health, her mental health, because she's going to be like a menopausal woman and she's only 16. So you are going to find those questions in the question bank. A patient who is more than 16, I wouldn't give her the GnRH pulses. I'm going to give a younger lady GnRH pulses if I discovered that she's having ovarian failure. Okay? So yeah, I'm going to give her the GnRH pulses so that I can mimic normal puberty. In older ages, HRT is going to be fine. And we start usually with estrogen until withdrawal bleeding happens. And then we can start the progesterone part. Okay? Do you have any questions? I know I have talked much. And if you go through this, it's going to sound easier. I hope. I hope. First investigation to be ordered in case of normal secondary sexual characters. And she is having primary amenorrhea, ultrasound. Okay? If ultrasound showed absence of uterus, this is mainly Mullerian abnormality, right? So in Mullerian abnormality, we are talking about also renal abnormalities. The whole Mullerian system is disrupted, so they are having, usually in 40% of cases, you can see renal agenesis. Renal agenesis, this is also a recall. So in case you want to look if she's having renal abnormalities also or not, we can go for MRI. But the main thing to diagnose uterine abnormalities, ultrasound, more specifically 3D ultrasound. Okay? If you have any question, I'm with you.